of honor, Dr. P.S. Shankar, Professor Emeritus, RGHS Bangalore, and Distinguished Professor, KBN University. I welcome our today's chief guest, Dr. G. Narsimlu, President, National API from Hyderabad, a senior rheumatologist of the country, a great academician, researcher, teacher par excellence, with many publications both at national and international levels. A dynamic personality in API has taken to API to a great heights, loved by all with great respect in API family of the country. I also welcome our other guest of honor, Dr. H.V. Srinivas, neurologist from Bangalore, a great clinician, teacher of teachers, researcher, known for his teaching for postgraduates and other faculty, written many books and chapters, closely associated with API Karnataka as well, recipient of many awards and recognition, a humble teacher. I also welcome our chief moderator, Dr. Satish Chandra, a senior neurologist, presently working as HOD Neurology in Apollo Hospital, Bangalore, former director of NIMANS, who has taken it to a great height in his tenure. A great academician, as well with many publications and recipient of many awards and fellowships. A great name in field of neurology in the country, who never said no to any of our earlier invite. I invite our today's dynamic speaker, Dr. Manjari Tripathi, professor and head of the department from the prestigious Institute of All India Institute of Medical Science, Delhi, a great teacher with special interest in epilepsy, a great name in field of neurology in the country, who never said no to our earlier invite, that speaks of dedication to teaching and training the students across the country, with many publications, both national and international, received many awards, a great researcher with a H index of significance in research. I also invite our today's panelist, Dr. B. Vengamma, a senior neurologist and presently the Vice Chancellor of Sri Devraj Aras Academy of Higher Education and Research, Kolar, former Vice Chancellor of Venkateshwara University of Medical Sciences, Tirupati, a holy place, a great faculty in field of neurology in the country, dedicated to teaching. I welcome our own organizing team headed by Dr. B. Mahalingappa, Chairman APA Karnataka, Dr. Ravi Kirti, Dr. Srinivas Murthy, and Dr. Suresh Sakra. I welcome all delegates who have joined from all over the country making a national event, which COVID-19 has taught a new normal life. Let us not waste time by reading their CV profile. Let us hear and learn from them. Lastly, welcome one and all. Now we have a formal virtual inauguration.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
We are virtually honoring all the faculty as well. Now I request Dr. P.S. Shankar for your introductory remarks.
Dear colleagues, we have assembled for a virtual program to celebrate International Epilepsy Day, and it happens to be the first function after the new office bearers have taken charge of the APA at national level. I am happy my distinguished student Narsimlu is heading the organization. I am equally happy to share the stage with Dr. Srinivas and Satish Chandra. Dr. Vengamma and Dr. Manjari are taking part in this program. Karnataka team is here in full quorum under the leadership of Dr. Mahalingappa. Epilepsy is a condition that affects millions of people worldwide. Despite the misconception and the stigma continues to surround its understanding and addressing. However, with proper diagnosis and treatment, nearly 70% of the people with epilepsy can live seizure-free. However, lack of awareness and access to the medical care prevent many to receiving the treatment they need. International Epilepsy Day is observed annually, and it serves as a vital platform to raise the awareness, educate the public, and foster a more inclusive approach towards epilepsy. Launched in 2015, International Epilepsy Day is the result of collaborative efforts between the International Bureau for the Epilepsy and the International League Against the Epilepsy. It is celebrated on second Monday, February each year, that is today 9th, and it is celebrated, and the International Epilepsy Day is a reminder to communities worldwide that epilepsy is much more than a medical condition and that epilepsy is a lived experience that requires understanding and support. Each year, a theme is given, and for 2026 is timing stories of into action, and it calls for concrete actions that turn epilepsy awareness into a meaningful change. It provides an opportunity for health professionals and people with epilepsy to come together and start important discussions about the neurologic health. Epilepsy is a neurological disease that causes recurrent, unprovoked seizures. Seizures occur where there is a sudden surge of abnormal electrical discharges in the brain, affecting how brain functions, while epilepsy can be diagnosed at any age, and it is most commonly diagnosed in childhood and older adults. Epilepsy is an umbrella term for a group of disorders characterized by recurrent seizures that vary in type and severity depending upon the form of epilepsy. Generalized seizures affect both sides of the brain with tonic-clonic seizures as seen in grand mal, brief staring cells in petit mal, myoclonic seizures, quick sudden muscle jerks, atonic seizures, drop attacks with sudden loss of muscle strength, facial seizures affecting awareness, juvenile myoclonic epilepsy, infantile spasm, and reflex epilepsy. Epilepsy can be caused by a variety of conditions such as genetics, brain injury, infections, stroke, brain tumor, development disorder, and idiopathic in many. It presents with sudden, jerky movements, loss of consciousness, staring spells, odd sensations, post seizure confusion. It must be noted that not all seizures involve convulsions. Though epilepsy is a well known condition, it is surrounded by many myths and misconceptions which have contributed to the stigma faced by the people. They are in the form of epilepsy is a mental disease. They cannot lead a normal life. It is contagious. Seizures always involve convulsions. Epilepsy is caused by sin and it is a punishment. And people with epilepsy should avoid a physical activity. Epilepsy only affects the children. To control it, put something in the mouth of the people having the seizure. Managing seizure effectively is one of the biggest challenges for the people with epilepsy. Treatment is highly individualized. Many individuals require multiple adjuncts to their medications to form an effective regimen, and some may experience side effects. In India, the prevalence of epilepsy has been estimated to affect more than 10 million patients, which makes it one of the most common neurological disorders in the country. The symbol of epilepsy that is widely recognized globally is the purple ribbon, symbolizing awareness, dignity, and hope. This color of purple enables individuals to show their solidarity and empathy with those who suffer from epilepsy. International Epilepsy Day 2026 serves as a vital platform to promote awareness, reduce stigma, and encourage informed conversations around the epilepsy. By understanding the condition, recognizing its symptoms, supporting timely treatment, and participating in the awareness initiatives, society can create a more inclusive and supportive environment for people living with epilepsy. Today's program is a well checked out, and we are eager to hear the lecture on all about the epilepsy by Dr. Manjari Tripathi, followed by discussions conducted by Dr. Satish Chandra, and I wish the program all success. Thank you.
Thank you, sir, for your overview of introduction to the subject. Now I request Professor H.V. Srinivas, sir, our guest of honor, to address the gathering. Over to you, sir.
Good evening, friends. The International Epilepsy Day is a worldwide phenomenon where all over the world creating awareness and removing the stigma. Now, the International Epilepsy Day is a combination of IBE and ILA initiative. We have an International Bureau for Epilepsy, which mainly addresses the social aspects of epilepsy, which is the most important part in managing epilepsy. The International League Against Epilepsy is a medical condition, medical faculty where the lot of research will be going on for epilepsy management. Epilepsy is an extremely easy condition to treat. Nearly 70% of patients with epilepsy can be well managed with minimum drugs. Only about 20 to 30% may require multiple drugs, and that invites specialists like Manjari Tripathi and Satish Chandra. 70% can be managed by a general neurologist like me. Not only neurologist, even a MBBS and physician, everybody can manage it. The unfortunate part of epilepsy is the myths and misunderstandings in the society causing stigma. In hypertension, diabetes, etc., people accept that, okay, you have got BP, you can get treated. But in epilepsy, it is not seen from outside. The person suffers from seizures and they try to conceal it because of the stigma. Now, what is the stigma? They think that a person with epilepsy is not normal. He cannot perform his duties normally. It is a hereditary illness, so child may get it like that. And so many such misunderstandings are there. That is the main source of treatment gap, what we call as. Now, in hypertension and diabetes, we educate the patient and the caregiver that you have to take treatment like this, and all. But in epilepsy, you have to educate the entire society. A child with epilepsy is denied admission into a school. A person who is capable of becoming a software engineer is denied a job. The person with epilepsy is denied sports and he is denied even a marriage. Why? All this because of stigma attached to the epilepsy and misunderstandings. That is where the IBE and the Indian branch, Indian Epilepsy Association, is striving to educate the society. It's not easy. How to educate society? You have to educate the children, and the school children and school principal. And you have to educate the employers. You have to educate the sports persons. You have to educate the entire society that you can get married and still do not have a child with epilepsy. It's a huge burden, very huge burden, which requires every one of us to participate in that. The theme in last year, 2025, was My Epilepsy Journey, with stories of personal experiences. Now, the theme for 2026 is to take it forward and then get an action from these stories. What action? We'll have to educate people. Even one person we educate, or one group we educate, or one lecture we give in the school, that is more than sufficient. Because you see, the problem is the entire society needs to be educated. So it's very easy to treat medical part of it. The social part is very difficult. And every one of us have to strive to educate public. Thank you.
Thank you, sir. Thank you for your kind words and sparing your valuable time. I request Dr. Malingappa, Chairman, API, to say a few words.
Yeah. Good evening. Greetings from API Karnataka. As Dr. Sangram Biradar has welcomed all the dignitaries, it's my job. It's a godsend opportunity for me. I am happy to see and hear today from the great and eminent neurologists from all over the country who made their mark in the field of epilepsy. And to my knowledge, if not correct, you can correct me, all are from NIMHANS, which is one of the institute which is the pioneer in the field of epilepsy. I remember when in primary health center, I was posted in NIMHANS for the epilepsy training in 1980s. And as Dr. Srinivas said, there were a lot of myths and stigmas today. You must be aware what was the condition in 80s. I was trained, and also I was happy to say that I was also trained under Dr. Satish Chandra during my PG days, and also Dr. H.V. Srinivas. I used to attend his clinics when I was doing my PG. Anyway, I am happy to be a part of today's seminar, webinar on the International Epilepsy Day. I welcome all of you to the today's program, sir.
Thank you, sir. Now I request our chief guest, Dr. G. Narsimlu, sir, President API, to address the gathering. Over to you, sir.
Thank you, Dr. Sangram. As a API president, I am privileged to be associated International Epilepsy Day, especially so to say the dais with my teacher, Dr. P.S. Shankar and H.V. Srinivas, who are eminent teachers, highly disciplined. I learned a lot of neurology from H.V. Srinivas. His prints are still alive with me. And P.S. Shankar, discipline nobody can match. Morning 8 o'clock used to be there, same discipline inculcated. Their blessings made me to take the responsibility of API president. And my other colleagues, Malingappa, Dr. Manjari, and other colleagues here, I wish this International Epilepsy Day goes successfully. I know a lot of stigma in the society. If somebody has epilepsy, they don't want to get married, they don't get job, and even having jobs, having a stepmotherly look on the people with epilepsy. The stigma has to be removed. There's no doubt about it. A person with epilepsy can lead a normal life with medications, with precautions. I have seen couple of people getting married, having children, come to know that the wife has epilepsy, going for divorce, and suffering, whole family sufferings, and that has to be removed. Not only that, newer advances in the field of medicine and especially neurology, imagology, EEG, PET scan, we made very accurate diagnosis of various forms of epilepsies. And newer drugs, so cute. They control most of what the cinema says, 70-80%. I feel, sir, it is nearly 90% epilepsy can control with pure drugs. It's only 10% we call refractory epilepsy. Dr. Sita was running this refractory epilepsy clinic in NIAMS Medical Sciences, there where we used to require multiple drugs. And today, a epilepsy patient can lead a normal life and they can do any job, except jobs like a pilot where you don't give high risk involved. A person with epilepsy is not given, but otherwise, epilepsy person can lead a normal life. These deliberations here will remove whatever the stigma we have in the society about the epilepsy patient and advances whatever taken place, make a uniform and a minimum skill level of the treatment for all epilepsy patients. As API president, we are allowed to get associated with all allied societies. Indian Neurological Society, Cardiology, all are part of the API. We have started inviting all the president secretaries to our national conferences and national CMEs. Joint to conducting things. Good number of neurologists, top neurologists are with a part of the API. API includes not only neurology, cardiology, rheumatology, all the things. Even though I'm practicing, I'm a rheumatologist. I started first time DM rheumatology. I was very much interested in neurology. Neurology used to be a long case for us. So later also, my interest topic was neurology. But a destiny made me to serve rheumatology much more because at that time rheumatology was not much developed. And we have very common issues, the antiphospholipid antibody syndrome, autoimmune encephalitis, polymyositis, AN-associated various neurological diseases. So we need to be thorough with the neurologist. As a rheumatologist, we need to have a very close coordination with all specialties. And I remember H.V. Srinivas teaching so cutely about any field in neurology. And P.S. Shankar imprints in me are very, very deeply imprinted. And I'm very much thankful to H.V. Srinivas and P.S. Shankar. And Vengamma, she now Devarajan is Vice Chancellor, but she was previously in Tirumal Tirupati Devasthanam Medical College, SC Medical College Director. I have associated with her. And the Manjari name well known in the field of rheumatology. And I wish this meeting to be successful and remove all the whatever the stigma is there and updates to be discussed. And I wish this meeting to be highly successful. Thank you all.
Thank you, sir. Thank you for sparing your valuable time. Now we move on to the scientific session. I request Dr. Professor Satish Chandra sir to take over the podium. Since all the faculty have been introduced, sir, over to you, sir.
Good evening. It is a very important day today. We are having International Epilepsy Day. As most of the speakers before me have told about the importance of celebrating the International Epilepsy Day on the second Monday of the February every year. And we are celebrating today for that and to create awareness about epilepsy, which has a lot of problems in the society, which has been already enumerated by my teachers and also friends here. So without wasting time, I was thinking that we should go straight away to the first lecture, which is by my Dr. Manjari Tripathi, who is a very well-known neurologist and an epileptologist from Delhi. And she is the professor and head of the department of All India Institute of Medical Sciences, very well known in the field of neurology and epilepsy. She is also an alumni of NIMANS, and she is working on various aspects of epilepsy and has a lot of publications in this area. And she is an apt person to speak about epilepsy in front of the physicians and to educate them on this important day of International Epilepsy Day. I think I will call on Dr. Manjari Tripathi to start her talk on epilepsy and overview. Manjari, over to you.
Thank you. Thank you so much to the organizers, Dr. Biradar, and my teacher, Dr. Satish Chandra, Dr. Srinivas, and all the honorable dignitaries who have facilitated this very important program on the occasion of the International Epilepsy Day. So as already said, epilepsy is very common. But something I want all students here to remember that the diagnosis of epilepsy is essentially a clinical diagnosis and close observation of the event and a good history taking by a clinician who's interested in what the patient has is enough very often to make the diagnosis. Now, it is a very common condition, and if you look at statistics, there are about 50, some people say 60 because the definition has changed. So about 60 million people with epilepsy, of which 12 to 13 million people reside in India. And most of these people reside in rural areas. So about half of these 12 million will be in the rural areas or areas with limited resources. It forms 30% of neurological disorders. So none of us can remain ignorant about how to diagnose it and how to manage it. Now, this is from almost 25 years back, and I do a lot of medical camps in rural areas. And what struck me in these camps is that there were young people who had epilepsy. As you can see here, this girl, that she's had something happen to her because she had all these burns on her face and her hand. And that signified the impact of epilepsy in that losing control of oneself, having a big seizure or a small seizure converting into a big seizure, focal seizure converting into a generalized seizure, can put the patient at risk for burns, especially if they're working in the kitchen, for injuries and falls if they are at heights, for drowning if they're in the water, and, shoulder dislocations, fractures, and the worst case scenario is sudden death. So it is, though, it is intermittent, it is chronic, it is unexpected. It is because of this unexpected nature that it leads to a lot of impact, not just at the physical level, but also at the mental and societal and community level, as has been asserted. Now, as I said, the clinical diagnosis of epilepsy rests on the eyewitness account. And, nowadays we have Uparwala, that is the CCTV or home mobiles. So particularly in patients who are unable, or the caregivers who are unable to tell us the history, we often advise them when they come to the outpatient, we take the history. Very often they'll say that the whole body was shaking and they haven't observed the beginning of the event. So we ask them to make, a mobile recording of the event right from the beginning. So it's like having, because we have so many mobile phones in India, it's like having half the epilepsy monitoring unit in everybody's home. So anybody who has a person with epilepsy in their house and whose seizures are recurrent should be given this advice right up front in the OPD. So all they have to do is two things. One is the first aid, and the second is the second observer, or if there's another person who's around them, can make a video. So we get these videos from very rural areas and from very remote areas. And you can see here that you can easily make out that the event is focal. So here you can see the head and eyes turned to the left, and the left hand jerking. And this is from a very remote village area. When they came to us, they said it's a generalized seizure, but actually it was a focal seizure. And this young boy who's singing in a national singing competition of Indian Idol, he is in the, in the preliminary rounds. And you can see here his eyes and head and whole body are turning, and nobody realizes he's having a seizure. So not just the mobile home video, but the situational CCTV video gives us a lot of information. So one had a left focal seizure, and the other had a focal gyratory seizure which turned to the left and then falling down. It not only helps us in establishing the diagnosis of true seizures, but it also helps us in suspecting functional dissociative seizures, which very often wrongly get started on anti-seizure medicines. And then it becomes very difficult to pull them off because you're not sure why someone has started the medicine when all you think that the patient has functional dissociative seizures. Now, right here, I would like the students to understand that all that shakes is not epilepsy. And we have a condition which is known as acute symptomatic seizures. As its name suggests, acute symptomatic seizure is something which happens within 24 hours to 7 days of an acute insult. That acute insult can be systemic, like hyponatremia, exposure to excessive of toxin like alcohol, hypoglycemia, hypocalcemia. So it can be a systemic event, or it can be a brain-directed event. It can be a meningitis, an encephalitis, a stroke, a head injury. So these are the cause of acute symptomatic seizures when they occur within 24 hours to 7 days of that event, whether it's systemic or brain-directed. These seizures do not require prolonged treatment. In fact, they require treatment for 7 days to 2 weeks, and then you can taper off depending on the sensorium of the patient. Sometimes you may need to give for longer, 3 months to 6 months. This is not epilepsy. This is what is known as a provoked seizure. This kind of patient should not be labeled as having epilepsy, because epilepsy carries a huge amount of stigma. And that is, we are working on it, but it is still very difficult to remove from the community. Hence, be very careful whether it's a provoked seizure, which is acute symptomatic seizure, and it is not epilepsy. We do have a definition of epilepsy, and that would mean that there is recurrent unprovoked seizures. So if you have 2 unprovoked seizures more than 24 hours apart, or even if you have a single unprovoked seizure where the neurologist or the physician determines that there is more than 60% chance of recurrence, and I'll come to how we determine that there is more than 60% chance of recurrence, then we say it is epilepsy. So it has to be unprovoked. And of course, if you have reflex epilepsy, then also you have, or reflex seizures, then also you have epilepsy, or you have an epilepsy syndrome like juvenile absence, juvenile myoclonic, or mesial temporal sclerosis, which is also a syndrome now. So that also is epilepsy. Now, the good thing in the current definition for every person with epilepsy is that there is an entity defined which is known as epilepsy cured. So suppose I have a patient who had seizures 10 years back, and we put them on medicines, and they took the medicines for some time, say 3 to 5 years, and the next 5 years they were off medicines. So first 3 to 5 years they were on medicines, their seizures were controlled, so the medicines were removed slowly, the doctor reduced it and stopped it, and the next 5 years they're seizure free. So total 10 years duration, of which last 5 years are seizure free. That person is designated as epilepsy cured. So this is a new entrant. Epilepsy cured is a new entrant in the definition of epilepsy, and this helps us to hugely remove the stigma of past epilepsy or past seizures which have happened. And hence this definition should be known by all of us. Now, it's very important to know that if a person has a single seizure or provoked seizure, and that single seizure has more than 60% chance of recurrence, majority of the recurrence will occur in the first 2 years. So you don't have to wait for long, you have to start medicines or not. As I told you, there are different kinds of epilepsy and there are different kinds of seizures. So you can have a focal seizure, and there are focal seizures of different types. We'll come to that. They're generalized seizures. And the same is in epilepsy, focal epilepsy, generalized epilepsy, and unknown. They can have various etiologies, and sometimes one seizure type can have two kinds of etiologies. For example, it can be genetic as well as structural. Like you have in tuberous sclerosis. You have a genetic abnormality in tuberous sclerosis as well as structural tumors which are causing the seizures. Otherwise, the etiology is broadly divided into structural, where there's a remote insult or past insult, like a past stroke 2 years back, a past head injury, a past meningitis, encephalitis in the childhood, which caused a structural damage in the brain. It can be genetic. There are many genetic syndromes. It can be metabolic. It can be immune, like post-autoimmune acute symptomatic seizures or post-autoimmune epilepsy. It can be infections, where the infection has occurred in the past. And sometimes in about 10 to 20% patient, despite all the investigations you do, you may not find a cause, and it is known as unknown. Now, epilepsy syndromes, which definitely define the person as epilepsy, are many. And it is important to remember as a clinician, not just to focus on the seizure type and the epilepsy type or the syndrome, but it is our responsibility to identify the comorbidities. And there are many comorbidities. There can be a psychiatric comorbidity. 60% people with epilepsy have associated depression. 40% will have anxiety. 10% can have psychosis. Sometimes it's a larger number. So this psychiatric comorbidity has to be identified and addressed, because if not addressed, it can lead to impaired quality of life and even threaten the person with epilepsy with attempted suicide. Then you can have comorbidity to do with cognition, with intellect. You can have comorbidity with bone health. So these are the various, or behavior. They can be hyperactive behavior. So there are several comorbidities which we also need to identify to give a holistic management to the patient. As I told you, epilepsy can be focal or generalized. And focal epilepsy is that epilepsy which involves very focal, limited networks in the brain. And it can spread to the other side, but it does not involve the diffuse cortex, the whole brain. Generalized epilepsy, on the other hand, involves bilateral diffuse cortex and almost the whole surface or the whole neurons simultaneously. Now, we have been updating the classification periodically, and the last update, which appeared in February last year, that is a year back, has clearly told and simplified the definition so that all clinicians at all levels can diagnose what kind of epilepsy it is. Why is this important? It is important for us to identify the seizure type and the epilepsy type, because there are different medicines for each type, which I'll come to. It's also important to identify the seizure type so that me as a clinician can talk in the same language to another clinician in Karnataka where I'm referring a patient. So if I saw a focal epilepsy, focal motor, then the clinician in Karnataka will understand that what I am meaning. So it helps in cross communication between treating doctors. The simplified classification is focal, generalized, and unknown. In focal, again, it's very simple. Consciousness preserved, consciousness impaired. Consciousness is tested by awareness and responsiveness. So both. And sometimes we are unable to know both in a patient because the caregiver would have never tested responsiveness and the patient may be amnestic for the event, and we may misdiagnose the patient as to be altered sensorium. So consciousness preserved or impaired and is in focal, and in generalized also you have the brief generalized seizures, which is the absence, which really do not cause a fall, or you have the other generalized seizures, which we'll come to, and then you have the generalized tonic-clonic seizures. Now, the focal seizures can get converted into bilateral tonic-clonic. And the generalized seizures can be typical absence, which is very brief, abrupt onset and offset, or it can be atypical absence, or it can be myoclonic absence, or it can be eyelid myoclonia with or without absence. It can be just myoclonic, or it can be negative myoclonic. It can be clonic. It can be epileptic spasms. It can be tonic, or it can be myoclonic atonic or atonic. So these are the generalized types. You have all kind of combinations here. Now, it's very important to understand that almost when you say focal epilepsy, we know it is focal, coming from a particular area. But when we say it is generalized, we say it is generalized, mostly it is idiopathic. Some people prefer to call it genetic generalized epilepsy, which I personally, in the Indian setting, do not like to call it genetic, because our population is not able to differentiate between genetic and inherited. So I will call it generalized epilepsy and then work on from there. In children, you can get several seizure types together and they formulate the developmental epileptic encephalopathy, and the etiologies are the same. Now, it's very important to remember that if you have only focal epilepsy, the spectrum of drugs which we use will be different. And if you have generalized epilepsy, you will use different spectrum of drugs. And sometimes using drugs of focal epilepsy for generalized epilepsy can worsen the seizures or prevent the control of seizures. This is just to give you examples of focal epilepsy, like temporal lobe epilepsy, frontal lobe epilepsy, occipital lobe epilepsy. These are focal epilepsies. Generalized epilepsies will be like juvenile myoclonic, juvenile absence, childhood absence, myoclonic or static. And then you have the developmental epileptic encephalopathies, which we see in children, which are often due to some genetic mutations and, have a worse prognosis. So sometimes it is very difficult for us to know whether it is generalized or focal. So here you see this young girl. She just tends to look to the right. She's not forced version. There's no forced version. She's just looking to the attendant on the right. And then she has some myoclonic jerks followed by generalization. So though it looks focal, it's actually a generalized tonic-clonic seizure. And this is what her EEG shows. It shows a generalized burst of polyspikes. You can see two or more spikes in one complex. So two or more spikes in one complex followed by a slow wave. So this is typical generalized epilepsy. And in a young girl who's a teenager, the diagnosis will be juvenile myoclonic epilepsy. And her ictal onsets are also generalized. Whereas focal epilepsy usually will come from a structural lesion. And this is absence epilepsy, where you can see this child is blowing into, is hyperventilating and suddenly stops doing it. So she stops hyperventilating. That's an absence seizure. And here the EEG will show generalized 3 Hertz spike and wave with an abrupt onset and an abrupt offset, which is brief. So this is a typical absence seizure. It's very easy to diagnose. It's very rewarding to treat, and you have very good medicines for it. I hope I have finished the first part of the talk, where I have tried to emphasize that epilepsy is not one disease. It's highly heterogeneous. There are multiple seizure types. There are multiple seizure syndromes. There are multiple etiologies ranging from genetic to symptomatic. And the outcomes can be very good, and the outcomes may not be so good, particularly in developmental epileptic encephalopathies. Hence, you cannot paint every person with epilepsy with the same brush, and one must try to prognosticate based on the seizure type or the epilepsy type, seizure syndrome, etc. As I told you, the history and the eyewitness account is most important, followed by the examination. Sometimes you get certain findings in the examination, and you have to do investigations. Hence, for a physician, if anybody comes with altered sensorium, which is brief and episodic, or a focal event, which is brief, first think in your mind, is it a seizure? If it is a seizure, is it provoked or unprovoked? If it is unprovoked, is it the first seizure of epilepsy? And is it focal or generalized? And what is the chance of recurrence? Based on that, we move forward with further investigations like EEG, semiology, imaging, in some cases genetics. Genetics is expensive, so usually I leave it till the end, and other tests. Now, sometimes the seizures will continue. It is because we have made a wrong diagnosis of epilepsy, and there are certain red flags. These are the red flags. You can have any of these disorders which mimic a episodic loss of consciousness. So any syncope, take the history. Did it occur just after going to the toilet? Did it occur just after they got up from sleep and, it was in the middle of the night and they had been sleeping and suddenly they had a lightheadedness and fell down? Did it occur when they coughed? So it will go towards syncope. Is it a TIA, particularly a limb shaking TIA, where one hand shakes followed by weakness? So is it a limb shaking TIA? Is it a TIA in the posterior circulation which can cause an episodic loss of consciousness? Is it parasomnia? Is there nocturnal walking, sleepwalking, or a RBD-like thing which is getting misdiagnosed as epilepsy? Is it cataplexy which occurs, which is emotion triggered in narcolepsy cataplexy syndrome? Is it recurrent hypoglycemic attacks? Is it due to certain drugs that they are taking? Is it due to alcohol? Is it due to alcohol withdrawal? Is it due to drugs like tramadol, which they're addicted to, or maybe eucalyptus oil, or, there are many other antibiotics which can cause seizures. So always take the history. Is it a focal spasm of multiple sclerosis? Or the commonest is functional dissociative seizure. And this functional dissociative seizure can occur in anybody. We have seen it in little kids who are being pressured to study and they don't want to study, or they have problems at school. We are seeing it in young girls. We are seeing in married women. We are seeing in men who have pressure for work. There's no earning. We have seen it even in older people. So these events are not seizures and they are coming from the mind and not from the brain. Always do an ECG, especially when the person is not responding or you are starting on sodium channel blockers, particularly the new drug lacosamide, because lacosamide affects the QT interval. So always do an ECG in all your people with epilepsy, not just an EEG, but also do an ECG. So this is a young lady who actually had a sinking sensation before she would become unconscious. And she's the wife of a cardiologist. And you can see here that she has a provocation of the tilt-table test and her hands jerk distally. These jerks are asynchronous. So this was misdiagnosed as epilepsy and she was put on carbamazepine, to which she was not responding, and she had a prolonged QT interval, which was much prolonged, and we had to pull off the carbamazepine, which was in fact making it worse. Then you can also have an elderly person, as you see here. He's the father of one of the doctors, and he complains of this pain in the chest, which was misdiagnosed as epigastric rising. And then he becomes unconscious. And then you will see his limbs jerk a bit. You can see his breathing is very sternus. And then his limbs will jerk distally. And it was misdiagnosed as seizures, and he was put on anti-seizure medicine. So you can see his right hand jerked a bit. That's it. This was... It always happens when he sits and then he turns and looks around. Okay. So if you see in the casualty itself, he did his ECG, and you can see flat. Okay. So wrong starting of medicine.
Not able to hear, or everybody is able to hear, or
functional seizures have alternating movements of the hands. You see her legs, alternating movement of the legs, turning, twisting, waxing, waning. She's on her toes, she's crying. All these features are features of functional seizures. So and it's very prolonged. So functional seizures are very prolonged. I don't think I have time to show everything. So psychogenic seizures must be suspected when the event is a big event. They say it's a big event. It's going on for 10-15 minutes, but it's never associated with urinary incontinence. It's seldom associated with a tongue bite. If there is a tongue bite, it's on the tip of the tongue. It's not associated with injuries. It never happens in sleep. There is pelvic uplifting or pelvic thrusting. There is alternate body movement. There is to and fro head movement side to side, or bizarre movements. So you must suspect functional seizures here. And as you can see here, in a functional seizure, there will be out of phase movements and there will be pelvic thrusting. And if you have a good nurse, or if you have a person who has a background who's observing the seizure, pupillary responses will be preserved. The hand will fall away from the face. Whereas in a true seizure, the hand will fall on the face, or the patient is often extends in a true seizure and not the patient's eye. And you will find the patient has eye to mirror contact or eye to selfie mode camera contact. That also says that the patient is conscious. In a true seizure, there will either be a staring look or there will be a version of the eye to one side, will be closed.
Madam, your internet is unstable, I think. Not able to hear clearly.
I will just put off my video because
Yeah.
that will.
Jerry, I think some internet problem is there. Dr. Manjari? I think she is off or.
I will talk with my video.
I think your internet is not clear. I think there must be some problem.
Can you hear me?
Yeah, we can hear now. Can switch off some of the videos so that they can get their internet better.
So not sometimes. Usually we do an EG, particularly if it comes within 24 hours of the attack.
The slides are not there, Manjari.
Slides are not there now.
Kindly reshare.
Manjari, your slides are not there. Hello?
Yes?
Manjari, your slides are not there.
Hello, am I heard?
I think you have to reshare your slides.
Manjari, are you there?
She is rejoining, sir. She is left and joining again.
Aha. Hello, some problem? It will be.
Brother, ನೋಡ್ತೀರಾ ಏನಾಯ್ತು?
We can call her up and find out, is there a problem?
I am calling, sir, calling.
Yeah. You can just call her up and find out whether there is problem with the network.
Audible?
Now it is audible, but your network is a problem, Manjari.
I don't know. I've switched off everything at my home.
Yeah, your slides are not seen now.
I'm so sorry for this. Yeah, I'll just share. So I'm so sorry for this. This is the first time this is happening. I'll try to share my slides. So I was telling the differential diagnosis of epilepsy, and yeah, so
Screen is not clear.
as I told, the diagnosis is clinical. Is it seen?
Yeah. Now we can see the slides.
Yeah, full screen me.
You can enlarge that slide view,
Slideshow.
slide show, slide view.
Hello. Hello.
Yeah.
Some
Your, I think network is the
network
problem.
issues.
Network issue.
Am I audible, sir?
You're audible, but intermittently it goes. Network is the issue.
Hello.
Yes.
Yeah. Can I continue, sir?
Yeah, we are able to hear
Can I
you
continue?
now.
Oh, Sharat.
Continue.
Sharat is-
We'll see whether you will be able to hear. Continue that at the moment. Slides are seen.
Jerry, you're muted.
Are not able to hear Manjari.
She is muted, sir.
Correct. I think Manjari, there is a problem. Shall we?
Manjari can continue talk without slides at least.
Manjari,
She
you
is
want to
muted,
continue
sir.
that?
She is muted, sir.
She must be resharing the slides or something.
They're already there, no, sir.
Dr. Biradar, were you able to get in touch with her?
No, sir, she's not lifting the call.
Oh,
Probably some network. She should leave and rejoin and stop
Yeah.
sharing all the videos.
I think she can continue her talk without slides, sir.
Yes, sir.
that's
There
what
is a
she can
problem.
continue.
Hmm.
Dr. Manjari, can you continue the talk without slide? You can keep in front of your laptop.
She is not there, sir. She's
She's not
No,
there at all.
she's
now it
there.
has come. She has come.
She has come.
Yes, she has joined, sir. But
No.
She has switched off her phone.
Oh, that's true. Yeah, she has switched off the phone also.
Hmm.
We are not able to get in touch with her. Shall we
um,
go ahead and discuss about it?
I
Vengama
think
is
we
here.
can start the panel discussion.
I think so.
See
That's what
whether
I
they'll-
was thinking.
Yeah. Whether
I was
she
thinking
will join
about that.
later.
Should we do that?
yes, sir. Please go ahead.
Yeah. I think she's calling. Yes, Manjari. Hello. Yes, Manjari. Sarath is also calling. Hello. I think we should go ahead with the discussion now.
Yes, sir. Please.
Yeah. Doctor, I think, so sorry for the interruptions. I think because of the network problem, we are not able to continue. 1 minute. Hello. Yes. Yeah, I can hear you, but Manjari cannot connect because of the network. Ah, 1 minute, I'll find out. It seems the host is not allowing to participate. It comes like that. Can you look at the Biradar? They are looking at it.
She is already
what I
joined, sir.
said.
She is already joined.
Yeah, but it seems it says host is not allowing to participate and audio doesn't come. They are at it. Hello.
Yes, no, sir. She is already joined, but not able
You
to
joined
enter.
already, but you are not able to speak. I don't know what is happening. They are trying to call, but
Sir, let her leave the meeting and rejoin once
hello.
again.
Yeah, but they are saying that they are allowing you already joined.
Let her leave and rejoin, sir.
I understood that. I've spoken to them. I've spoken to them. They say that it is not. They are not doing that. Yeah, you join again once more. She's joining again once more and trying to get in.
No, sir, sir.
Because
She is already joined. Let her leave and rejoin.
Yeah, that's what she's doing. Hello. Oh, it seems still it says that the host is not allowing to join, even though she rejoined.
No, sir. Her name is reflecting here.
But she
She has
says
not
that
left exit. She has not exited.
that's what she says, that the host is not allowing. That's why it is coming, and she is not able to do that.
And
She is
now
not-
it's there.
Now I think she may join.
Hello.
Hello, yes, now we are able to hear you.
So are you able to see my slides, sir?
Yeah, we are able to see the slides also. You can show the slideshow.
Okay, sir.
Yeah.
So,
you can see them.
I'm sorry for this interruption, but maybe it was a transient neuronal network dysfunction.
Yeah,
So,
it looks like that.
so epileptiform discharges in EEG help us corroborate the diagnosis. But if we find an abnormal EEG, so there is a scoring. I told you that a single seizure, we as clinicians have to decide whether the single seizure which is unprovoked is epilepsy or not. So if there's an abnormal EEG, an abnormal neuroimaging, abnormal neurodeficit, then the score automatically becomes 2. And 2 means there is a high risk of recurrence. So you have to do an EEG, you have to do the neurological examination. You also have to look for imaging abnormality. And automatically the risk of recurrence will become more than 60%. And it will help you decide whether that single unprovoked seizure is actually epilepsy. So the patient should be looked for all of this. Now, we have to treat the first seizure, particularly if it's associated with neurological comorbidity, with mental retardation. If the first seizure was status epilepticus, if the EEG and MRI is abnormal, or if the person never wants to have another seizure and has a high-risk job. So counseling is required, and a case-by-case approach, estimating the risk of recurrence, is also needed when we start the patient on medicines. Now, the good news is, as senior professors told here, 70% of epilepsy gets controlled by 1 or 2 medicines. It's only 25 to 30% which remains refractory and needs further evaluation. Now, the management is in this 70% is pharmacological, but there are non-pharmacological measures for the remaining 30%, which include diet, which include possible surgery and investigations. We have old drugs. When I did my DM at NIMHANS, we had just carbamazepine, valproate, phenobarbital, and phenytoin. Now we have ethosuximide. We have newer drugs. We have the middle-level drugs like lamotrigine, levetiracetam, oxcarbamazepine, topiramate, zonisamide. We have the third-level drugs, which are like lacosamide, zonisamide, etc. And we have cannabidiol and other unconventional drugs like estazolamide, ACTH. So there's a host of drugs. it's very important that all the drugs mostly are taken orally by outpatients. So we must be able to screen when we start patients on drugs for adverse effects on the skin, for adverse effects on the heart, for adverse effects on the liver, particularly if it's valproate, or pancreas also, and bone marrow suppression, particularly with phenytoin, carbamazepine, ethoxamide, etc. There are certain gross side effects of phenytoin. That's why we don't use it in women, like gum hyperplasia and hirsutism. With carbamazepine, we have to be cautious about hyponatremia. With valproate, particularly in elderly, hyperammonemia, which can lead to secondary Parkinsonism, weight gain, polycystic ovaries, and with topiramate, renal stones, and acute angle closure glaucoma, and sudden blindness. The worst reaction you can have is with the aromatic anti-seizure medicines, which have an aromatic ring to it, like phenytoin, phenobarbital, carbamazepine, oxcarbamazepine, lamotrigine. Sometimes can produce a rash, which can be actually fatal because it can cause toxic epidermal necrolysis. And hence we have to warn these patients. And this is particularly common in the Southeast Asian population. We have to know which drug to select where. So if it's a generalized seizure, we use valproate, levetiracetam, clobazam, topiramate. If it's absence, we use ethoxamide and valproate. If it's focal, we use carbamazepine, phenytoin, oxcarbamazepine, lamotrigine. And atypical absence, we will use valproate, lamotrigine, topiramate. Now, there are certain broad spectrum drugs, and you'll see the broad spectrum drugs are those where everything is marked in green. So generally, broad spectrum is supposed to be levetiracetam, valproate, clobazam, zonisamide, so these, and topiramate. So these act for focal seizures as well as generalized seizures. Now, certain syndromes, there is a drug of choice, like juvenile myoclonic epilepsy, except in women of childbearing age. The drug of choice is valproate. In women of childbearing age, we will use levetiracetam or lamotrigine. And the other choices are given like zonisamide and topiramate, but they cause fetal neural tube defects, particularly the topiramate and valproate we should not be using in young girls who are likely to be of childbearing age. Juvenile absence, valproate, ethoxamide, lamotrigine, zonisamide, and topiramate can also be used. West syndrome, we know prednisolone, oral prednisolone, or ACTH, pyridoxine, and Lennox-Gastaut syndrome, where we use valproate, lamotrigine, topiramate, and benzodiazepines. So this is just a holistic chart to give you that different kind of seizures have responsiveness to different kind of drugs, and this is by Jacqueline French, who has given this in Journal Neurology. As I told you, that different syndromes have different seizure types, but it is very important to remember some anti-seizure medicines can actually worsen seizures and particular seizure types. For example, if we give lamotrigine to a patient with progressive myoclonic epilepsy, then the myoclonus can worsen. If we give carbamazepine, oxcarbamazepine, phenytoin to a patient with juvenile myoclonic epilepsy, the myoclonus can worsen and even abscences can worsen. If we give phenytoin to a patient with absence or myoclonus, they can worsen. So one has to be very careful as to what kind of seizure type it is so that we actually don't aggravate the patient's seizures. I prefer using extended release formulations wherever possible because this avoids a peak and trough level and gives a steady level in the blood. Particularly in women who are likely to be pregnant, an extended release preparation will prevent peak dose effects and harmful effects to the fetus at a particular time of the peak dose. As I told you, the patients with epilepsy can also have comorbidities. It is not uncommon for a person with epilepsy to have migraine. There we would try to use drugs like divalproate, topiramate. A person with epilepsy can have depression where I would try to use oxcarbamazepine, lamotrigine, or carbamazepine. They can have chronic pain associated with epilepsy where I would try to add carbamazepine or lacosamide, and if that fails, then maybe gabapentin or pregabalin, though gabapentin and pregabalin do not have a very good anti-seizure potential. If a person is very obese, I will give zonisamide, topiramate, but I will ask them to hydrate very well, 3 liters, 2.5 liters of water, because they have a carbonic anhydrase mechanism of action and there can be renal stones. So you need to hydrate them well and there can be hyperthermia, particularly in Indian hot temperatures. Women of childbearing age, we will avoid valproate. Older adults, we will give either levetiracetam or lamotrigine. And if there is already kidney stone, we will avoid giving topiramate and zonisamide. So you have to look at comorbidities also when you prescribe. Always try to look whether you're using an enzyme inducer or enzyme inhibitor. Enzyme inhibitors are valproate and topiramate. Enzyme inducers are carbamazepine, oxcarbamazepine, phenytoin. These are enzyme inducers, and you would avoid using them with other inducers so that the levels decrease, or with ATT, where the level of ATT and the antiretroviral drugs can reduce. Now, we often are sent consults from general physicians, and we are told to, because the patient has had a seizure in the nephro ward, the patient has had a seizure in the transplant unit, or hepatic, patient in the gastro ward. So generally, you should remember, by far, the innocuous drug is levetiracetam, except in renal failure, where the dose of levetiracetam has to be adjusted according to creatinine clearance, and it has to be avoided in end-stage renal disease. The safer drug to use in renal disease is valproate. But otherwise, if you have heart disease, hepatic disease, liver disease, renal transplant, bone marrow transplant, porphyria, hypothyroid, you can see the safest to use is levetiracetam. And there are other drugs which have been listed here. Now, always the principle should be start with one drug and build that up slowly till it reaches full tolerated dose. So if the dose of phenytoin is 5 milligram per kg, in a 50 kg, you will give 250 milligrams. Now, you will avoid using very high doses to produce toxicity. The moment you increase the dose and some side effect appears, but the seizures are continuing, so there is a partial response, but the side effect has appeared to the higher dose, you will add a second drug. And the second drug should be synergistic. So always start with one drug and build it up to full tolerated dose. But remember, do not give homeopathic doses of 4 drugs. It is useless. Very often I see prescriptions still where patients are still having seizures, and the patient is on, he's a 70 kg person and he's on 50 milligram BD of lamotrigine, 200 milligram of phenytoin, and levetiracetam, 250 and 500. So these are microscopic homeopathic doses, and the patient is on 3 drugs. Nothing is working. So always I would have started levetiracetam, built it up to tolerated dose, and then added the second drug, rather than add 3 drugs in microscopic doses. Always emphasize on lifestyle. They must sleep. All of us, even people who don't have epilepsy, should sleep for 7 to 8 hours. People with epilepsy more have to sleep for 7 to 8 hours. They should avoid alcohol, avoid smoking, avoid drugs which can provoke seizures, including eucalyptus oil. They should not take too much of stress. And of course, they should have supervised medicine. I always tell my families that please supervise the medication. See that your loved one has taken the medicine right in front of your eyes. Otherwise, a person with epilepsy will think they have taken the medicine because they remember yesterday's dose which they have taken and they miss the dose. Always have a follow-up plan, a monitoring plan for your patient. Particularly if the girl is going to get married and planning to have children, have baseline serum levels, because we know in the 3rd trimester, the levels of drugs will fall. So before she is pregnant, have a baseline serum level of the drug so that you know what is going to happen in the 3rd trimester, has it fallen or not. Do WBC counts, because certain drugs like carbamazepine, phenytoin, they'll reduce the WBC count. Do thyroid function. Carbamazepine causes hypothyroidism. It increases lipid profile. So you just can't just leave them saying that nothing is needed. You need to follow them up. In certain cases, you need to do levels, particularly if the patient is not responding or you're suspecting toxicity. Always send them with a seizure chart. And it should have different seizure types listed in awake or asleep, because that will give you a clue as to what kind of epilepsy it is. So always give them a seizure chart. This is the seizure chart we give, so that they are able to mark out and tell us when they come back, because otherwise they will not remember, and they will underestimate the seizures, and they will tell something from their imagination that Caesar was 1 week back or 1 month back, when actually the person could be having Caesar every week. As I told you, anti-seizure medication levels are not routinely indicated except when you suspect adherence, suspect toxicity, when the seizures are still occurring despite taking the dose, and in pregnancy. In these conditions, you will always do a serum level, and the serum levels are given here. The newer drugs, the serum levels are very, very expensive to do and available only in very advanced labs. So you should be cautious about, just doing blind levels and increasing the expenditure on the patient. Always treat the patient and not the drug level. A person with a suboptimal level could be having full seizure control. When to stop medicines is another class by itself. Generally, if the patient has seizures which are well controlled, it is not a highly epileptogenic lesion like mesial temporal sclerosis, we try to taper the medicines after 2 to 3 years of seizure freedom, provided it is focal and not JME. In JME, we give medication for much, much longer, and sometimes for 10 to 15 years. Now, when we taper the medicines, we have to tell them that the tapering has to be done very gradually. They have to avoid driving during tapering. They have to avoid lack of sleep, stress, etc. And I personally taper not more than 20 to 25% every 2 months. And we also tell them there's a 25 to 30% chance of recurrence. So you have to tell them that. Now, sometimes seizures will continue, and that is where we as clinicians should look at A, B, C, D. A is the accuracy of the diagnosis. B is the best drug. Have you chosen the best drug? You're not giving JME, carbamazepine. C is the adherence or the compliance. And D is the dose of the drug. Before you say that the person has truly refractory epilepsy. Truly refractory epilepsy is where 2 drugs in good doses have failed to control the seizures. That is when the patient should be referred to a center like NIMHANS or Shri Chitra or AIMS or wherever, so that workup can be done. We are not referring the patient for sure shot surgery. We are just referring the patient for workup, and sometimes even adjusting the doses at a tertiary level center, or just giving a special diet in a patient who has a normal MRI can control the seizures, and the patient doesn't always have to go for surgery, but at least the complete workup is done. Here we do video EG, where we try to document seizures, 3 typical seizures. We do harness protocol MRI, which is 1 millimeter section. It takes about an hour to do to pick up the lesions, and these subtle lesions can be missed in the 5 millimeter or 8 millimeter routine MRI, which is done just for 15 to 20 minutes. Epilepsy protocol MRI requires at least 45 minutes to an hour. We try to look at the semiology, the video EG, the MRI, and try to find out if it's coming from a focus. I'd like to, the last few slides will be for the junior doctors, particularly status, which is, time is brain. We have to tackle status immediately. So within 5 minutes, ideally, we should stop the seizures. For this, all patients with epilepsy should have the prescription of intranasal midazolam. It is available in 1.25 per ml. Per ml. So here you have to give 10 milligram in an adult and 5 milligram in a child. This is out of hospital person with epilepsy. But if the person is in casualty, you have to give it IV. If IV line is not available, don't waste time. You can give it intramuscular. It will act as well as IV. If the patient's seizures are continuing beyond 5 minutes, then it's status epilepticus. Within the first 30 minutes, we have to load with levetiracetam, 60 milligram per kg, or we can give valproate. I rarely give phenytoin nowadays because phenytoin has to be given at a very slow rate, whereas levetiracetam and brivaracetam can be given in 5 minutes. If 2 first-line agents fail, we have to arrange an ICU bed. While we are arranging an ICU bed, we can give Rylstube perampanel, we can give Rylstube topiramate to stop the seizures, we can load with lacosamide. In the meanwhile, the resident would have arranged an ICU bed with a ventilator, and that is where intravenous continuous infusion of midazolam can be given. If blood pressure starts falling with midazolam, you add ketamine, which is good to add on early. Always tell your patient's relatives, nothing has to be done during a seizure except turning the patient to the side and loosening a tight button. Nothing to be put in the mouth, the nose, except the drug, which is midazolam. Nothing to be, like onion or shoe to be, made to smell them. This is still happening in many parts of our country. Very important topic, pregnancy. Now, we know young girls, they get married and their families want them to get married. We try to tell the young girls to first get educated and have a job. However, sometimes socio-culturally, it is impossible, and the parents get the child married off and come to us after marriage. It is important to remember that it is immensely possible to get married and have children. And if you have chosen the right anti-seizure medicine, 95% pregnancy is safe. This is a message each and every physician and neurologist should tell, provided you have chosen the right drug. You have avoided valproate, you have given levetiracetam or lamotrigine in good doses, which have controlled the seizures. It's very rare that a person will not respond to these. If they don't, then you have to give very low dose valproate with caution, and you should have taken the signature from the patient. Remember, malformations can occur even in women without epilepsy to the tune of 3%. So the message that everyone should give is 95% pregnancies have a good outcome, provided they are on monotherapy. I will not go into this because the time is less. There are mechanisms which I can take in the question answer session. As you can see here, that the rate of malformations is higher in monotherapy with drugs like ethoxamide and valproate and topiramate and phenobarbital, phenytoin. With levetiracetam, the rate of malformation is the least, followed by lamotrigine. And this is just to show you that if you give, there are various registries. There's URAP registry, American registry, there's UK registry. The Kerala registry was amalgamated with the URAP registry. And it is clearly seen here that in all these registries, the highest malformation rate is with valproate followed by topiramate. This is dose dependent. If the dose of valproate is below 600, 700 milligrams, the rate of malformation is about 5% or so and ranges from 5 to 7%. But if you increase the dose between 700 to 1400 milligram, the rate of malformation doubles. It becomes 10% or so. And if you go above 1500 milligram of valproate, it becomes 20 to 25%. I don't remember using valproate in that dose in any of the women. If I'm forced to use valproate, I generally use 400 to 600 milligram when they're not responding to levetiracetam or lamotrigine. It's very important to remember that children of mothers who are taking valproate have higher incidence of malformations. And of course, their cognitive function is also impacted. As you can see here, with valproate, the IQs are lower. And also, you have to supplement with folic acid because folic acid not only protects the child from malformation, but also is known to improve, not allow the IQ to deteriorate in those women who are on valproate. So you can see here the dashed line and the solid line. The solid line is valproate with folic acid. The IQ is better. The same valproate dotted line without folic acid, the IQ is worse. So folic acid also impacts the IQ of the child, and you must use any anti-seizure medicine, valproate must be given. Now, there's a debate on the dose of folic acid. There's evidence in literature of large population study from Norway where they said that high doses can predispose the mom to cancer. Though I'm not sure that is so in our population. We can give half tablet of 5 milligram because we have 5 milligram in our country. And there is a protocol for monitoring pregnancy. This is very, very important. You must tell them all pregnancies with epilepsy have to be monitored. They have to be registered and the delivery has to be in a hospital. 16 weeks, you will do serum alpha fetoprotein, 18 weeks, a fetal level 2 ultrasound, and then you will give vitamin K in 2 doses. You will do a thorough neonatal examination. If the level 2 ultrasound shows a fetal malformation at 16 to 18 weeks, you will, and it's a major malformation like a huge myelomeningocele, you have to inform this to the parents. Even a minor malformation like a cleft lip has to be informed. And you have to educate them that the cleft lip can be corrected, but a major malformation is a decision which the parents have to take as to what to do with the pregnancy. We are allowed to terminate pregnancy up to 20 weeks. With special permission, at AIIMS, we have terminated even at 25 weeks. In pregnancy, we must monitor the levels. As I told you, in the 3rd trimester, lamotrigine level dips by 80%. Levetiracetam again dips by 70%. So you will have to increase the dose of the medication. In the elderly, we may have to use drugs, particularly drugs like levetiracetam and lamotrigine, because they do not interact with other co-prescription when the elderly is taking, like for heart disease or for blood pressure. And in an elderly person, a single seizure, you will start treatment. You will not wait for the second seizure because the impact can be huge. Always start low and go slow in an elderly person. Don't give full doses day 1. And it's always better to treat the first episode also. I think I will conclude by this, and I would like to take questions. I did not touch upon oral contraceptives that can be discussed in the panel. And again, contraception is something which needs to be advised, particularly to the young girls, because they very often do not know the methods. And we should be able to tell them to take non-estrogen containing contraceptives. Nowadays, most of my patients are on depot medroxyprogesterone, which can be given, injection can be given every 3 months. It works very well, or progesterone only pill, which are the POPs. So these are the ones which I advise my patients, especially if they've not had a child. Once they've had a single baby, then I advise them copper tea. With this, I'd conclude, and I'm sorry for the interruption, and thank you so much.
Thank you, Manjari, for an extensive coverage of the subject in a short period of time. And you tried to cover most of the aspects. And I'm sure there may be a few questions in the chat box, which I'll be looking at. And we can take it up one by one, depending upon what is the questions. Otherwise, I'll be asking few questions to make it clear rather than the subject is so vast. That's why I would ask few questions to make it clear. Maybe repetition also. I have along with Manjari, Dr. Vengamma, who is also very much interested in the field of epilepsy and done a lot of work in the field of epilepsy. So hence we have two people to answer the questions. I think from the chat box, most of the questions have already been answered. So I will take it up in a different way. So the questions are whether at different ages the patient can come to you, starting from birth till the last day. Anybody can have seizure. But when the child comes to you with a seizure, there are certain things which mimics like epilepsy, and the parents are very much worried that whether these are epilepsy and what should be done. Can we differentiate this from other conditions, maybe like a breath holding spell in a small child, or whether it is a night terror or a sleep disorder? Dr. Vengamma, how do you differentiate these conditions from that of epilepsy? Vengamma, are you there?
Yes, sir.
Madam, you can unmute, madam.
Vengamma,
now I
unmute
can.
yourself.
Thank you, sir. I think what already it is mentioned that the history of the episode is the most important. Some, especially in children, you can get that febrile convulsions with the fever. That's very easy. But differentiating breath holding spells, we should take the detailed history, how it started when the child started crying and holding on to this one. Then we have to check it, and when there is a cyanosis, change in the color of the lips or the fingertips, if that is there, it goes like a more of a breath holding spell. Most of the time, the classical history in breath holding spells is child will be asking something, the mother or parents, they say, we'll do this one. Then suddenly child starts crying and then holds the breath, and then it's, I think that history is very important. Another thing, like during the sleep, sometimes it could be the nocturnal seizure, but which stage of the sleep, what is the description? Maybe sometimes the night terrors and the seizures during the sleep may be difficult. Maybe we have to do the EEG and then see the attack by the whatever recorded from the mobile video. Then only we can make it out. But breath holding spells, definitely we can differentiate with the history. Sleep, I think we have to check which stage of the sleep, what is the description, can sometimes will tell you the night terrors are differentiate, but sometimes it may be difficult to differentiate.
Yeah. Dr. Manjari has already told about many syncopes which can be differentiated from that of the epilepsy. And especially in elderly people, when they come to us, it is always a problem to differentiate whether it is a vascular episode or whether TIA or whether it is a seizure, which is always a differential diagnosis in a little older people. As the physicians, they are all getting these patients, they come to their consultation because they are the first people whom they approach. So how do you guide them that these are not epilepsy and these are the syncope, or whether it could be a vascular episode? How do you differentiate them, Dr. Manjari?
So it's fairly simple. Syncope will usually happen in a standing position or even a sudden sitting up. It will usually never happen when the person is lying down. The syncope will be associated with a sense of lightheadedness, that the head is swimming. It is lightheaded, and a sinking sensation, that is a curtain coming before the eyes or darkness coming before the eyes. It is associated with sweating and palpitations, and usually the person falls to the ground and gets up immediately. It doesn't take, post-ictal state of half an hour, 15 minutes. No, usually they get up immediately. And usually these people will either have a trigger. The trigger can be cough, micturition, it can be sudden change of posture, it can be seeing blood, or it could be intrinsic cardiac rhythm problem or a QT interval problem. So the other thing is, in syncope, there can be jerks, but these jerks are asynchronous. So one hand goes up, the other hand goes down, and they're distal. So syncope has asynchronous distal jerks or finger-leg jerks. They are not tonic-clonic. They are asynchronous distal. Whereas in a seizure, they are tonic-clonic. The other thing is, in a syncope,
Muscular episodes.
yes, syncope, generally the eyes will be uprolled. Whereas in a true seizure, either the eyes will be versed or uprolled or staring. So these are the features. And if there is an intelligent caregiver, they can even feel the pulse and see if the pulse is hypovolemic. So syncope can be made out. Sometimes it's very difficult. And in these patients where it's very difficult, we often do the precipitation test in the tilt table in the cardiology lab. We take them there and do it, or we get a Holter long loop, long recording. Sometimes you have to do a long loop recording because 24-hour Holter may not pick up, and you have to put a 1-week Holter, which is available now, disposable. So you can put a 1-week Holter recording also to pick it up. So particularly in elderly, one has to suspect a cardiac origin.
So you always mention that epilepsy, we all say that it is a clinical diagnosis. And most often the clinical diagnosis will always confirm that. So when will you ask for an EEG? Do you think that every patient has to go through the EEG? Is it required or not required? And when will you do an MRI or a CT scan? When will you choose the imaging as a mode for the diagnosis of epilepsy or confirmation? Dr. Venkamal?
Sorry.
Thank you, sir. I think especially in children, most of the time it could be idiopathic. Imaging may not help. But for any patient with an adult or adolescent, all partial seizures, imaging has to be done. And I think any seizure after the age of 20-25, there needs to be imaging to be done to find out the cause, and especially if there are focal seizures any age, they also need to be done investigations. Another thing, if you have to see if there are any metabolic conditions like elderly with the diabetes, hypoglycemia, or those things, you may not require. But EEG will definitely help whenever you suspect, especially idiopathic or genetic generalized epilepsies like absence or juvenile myoclonic epilepsies. Children, definitely EEG will definitely help. Of course, in partial seizures, complex partial or the temporal lobe seizures, EEG will definitely help. Generally, in children, we don't, for all generalized epilepsies like absence or juvenile myoclonic epilepsies, imaging may not be required because it will be normal. Most of the time we see with the children with absence, they come with an MRI CT. It may not be required. In those conditions, like JME and absence, any of these genetic generalized epilepsies, ideal to do EEG rather than imaging. In contrast, if there are a partial seizure, EEG may not pick up focal seizures. It may be better to do the imaging to find out the structural lesion. Any single seizure, or if there are associated neurological deficits, or if there is a partial seizures at any age, definitely needs imaging studies.
Okay. So you do EEGs in most of the cases, and it helps it. And MRI you choose when all focal epilepsies And for the first time, especially in an older person, you always do an MRI or an imaging. MRI is more useful than a CT scan. Am I right? That is what you are
Yes,
asking,
sir.
informing? Yeah.
Yes, sir. Yes.
Yeah, that is the way it is. So, Dr. Manjari, one of the other thing is a young lady who comes to you and they complain that they have anti-epileptic drug. What are the chances of they developing a PCOD, which is a major problem in young girls? So, do you think that these anti-epileptic drugs are responsible? And then how do you proceed with investigations and how do you evaluate?
So this is a very important question as well as a very debatable and a controversial one also. Now, the incidence and prevalence of PCOD in general young girls who do not have epilepsy due to dietary factors, due to hormonal factors, due to lifestyle choices is also very high and increasing. Young girls who never have had a seizure also have PCOS. So, but particularly when you are on certain drugs like valproate, which makes you gain weight, the incidence of PCOS again shoots up. There are enough studies to show that valproate is associated with PCOS. So I would not say across the board all drugs are associated with PCOS. I would first always, when we are seeing a young girl, we should always take the menstrual history, because we as neurologists not very often do not take the menstrual history before starting the any anti-seizure medicine. So always take the menstrual history and document it. Very often you will find that they've had 1 or 2 seizures, they've come to you for starting medicine, and they already have irregular periods. They already have cycles coming in 6 weeks. They already have either very little period or very heavy period, and they are already obese. And they already have partial features of PCOS. So this person already has pre-morbid, pre-medication start PCOS, and you're definitely not going to make start drugs which will make them gain weight and become more, have more PCOS. So always take a background history of the menstrual cycle, whether or not you are going to start valproate. And I don't remember starting valproate in a single girl who's teenage in the past, I think 7-8 years. I have never started valproate. I have usually started levetiracetam or lamotrigine. Lamotrigine I start only when I have time to titrate the dose. But if I want quick action,
You need to start low and go.
Yes.
Yeah, that is very important. That is important message that when to do, can we type them? Can we make the diagnosis in these patients early and then avoid certain drugs? That is what is very important to see there. And you also said that comorbidities are very, very important. And you also mentioned that it is better to list out whenever you are sitting in a clinic and you are making a diagnosis of epilepsy. Also list out all the comorbidities what the patient has. It may be a sleep disorder, it may be due to migraine, it may be due to headache, and then patient has seizure, which drug to choose and how to choose. That will help us when we know the comorbidity. There is a question in the chat box, Dr. Malingappa has asked that anti-epilepsy medicines with the least side effect in pregnancy, particularly in the first trimester, to be avoided. Which one to be avoided and how to use that? You have already mentioned that. Maybe you can clarify it better.
So all the evidence which we have is thankfully based on large population pregnancy registries. And these registries have clearly shown us that the safest drug is levetiracetam followed by lamotrigine. And these drugs are broad spectrum drugs, except lamotrigine and PME you will not give. So lamotrigine or levetiracetam is the safest in the first trimester. With valproate, the safety is not there, particularly if the dose is above 700-600 milligrams. But sometimes, I have 1 or 2 patients every year where levetiracetam is being given full dose. We are giving 3 grams of levetiracetam and seizures are still happening. So then you add lamotrigine, you build it up to 5 milligram per kg slowly, still the seizures are happening. And then you just add very low dose of valproate and the seizures stop. Yes. So there then Then we bring down the lamotrigine and levetiracetam, try to maintain them on a monotherapy of very low dose valproate. And I take their signature in the file saying that there has been no response to levetiracetam and lamotrigine tried in good doses. Seizures are continuing, and the impact of seizures is continuing on their lifestyle and quality of life. And hence, after telling them the adverse effects of seizures, recurrent seizures, there are adverse effects of recurrent seizures also, and the adverse effects of valproate, both on the pregnancy as well as the IQ. We are starting valproate, and we take the signature of the caregiver as well as the girl. Sometimes they refuse to start valproate, even though they're responding to valproate. They say, no, if I become pregnant, then I don't want valproate. I don't want my child to suffer. In which case, we have to taper the medicine, but the risk of seizure recurrence is there, and it does occur in these exquisitely sensitive people to valproate. So valproate is definitely to be avoided. Clobazam, in the Indian registry, clobazam was associated with higher malformations. Again, I will avoid it in the first trimester. Topiramate is associated with higher malformations. I will avoid it. Phenytoin, definitely I will not give. Phenobarbital, I will not give. For focal seizures, carbamazepine is okay. Oxcarbamazepine is okay. That also I can give. So I hope I have answered the question. Levetiracetam, lamotrigine.
Safe drug, according to you, in the first trimester will be levetiracetam and lamotrigine. These are
Yes.
the two safe drugs, and other drugs should be avoided as far as possible, and plan the pregnancy well before they conceive. That is what the message which you are saying. I think that is the way to move forward, and I think we should guide the patients well before they become even conceive them. That is what is very, very important. Dr. Vengamma, some lifestyle changes we always talk about when we are talking about epilepsy and the management. What are the lifestyle changes which you advocate in your patients?
First, most common is the sleep, sir. At least we should tell them that they should have a minimum 7 to 8 hours sleep. And if they are on night shift, we try to tell them that to avoid night duties. Suppose in case if they cannot avoid night duties, at least out of the compensatory that 7 hours sleep or 8 hours sleep, we tell them definitely they should take in the at least they should sleep in the morning. Out of 24 hours, I think they should have a minimum 7 to 8 hours sleep is a must. Another thing we always tell them is the regular timings of the drugs also. That's also part of it, because one day they take drugs at 12 o'clock in the noon, another day they'll take at 8 o'clock. We tell them, no, you should have a regular meals timing, so that the breakfast, lunch, dinner, ideally better to have a single dose, but sometimes you may have to give 2-3. We tell them to have a regular drugs to be taken on a fixed time, so that the drug levels will maintain, it becomes better. Another thing, of course, is the diet. They should not like sometimes, especially if for some festivals, fasting, all they say they will avoid the food. That's why they don't want to take, especially in that Ramadan time, we see a lot of them, because whole day they will not take the food, and that's why they're fasting, and they start taking everything in the night. If that sort of a thing has to be done, I think discuss with the doctor, take an extended preparation or a long acting preparation, so that that's why better to avoid this fasting, this one. Another important thing is avoid the late nights, especially in the current adolescents. You see a lot of them will be awake till night, 12 o'clock, 1 o'clock, and lot of watching the computers, and then late night movies, late night film, those sound. If they have some related to photoparoxysmal epilepsy, photosensitive, we should at least tell them that even in the house, when they watch TV, they should sit at 20 feet and use remote. And then if they are using continuous computers, then ask them to put a guard on the computer, so that your eye strain will become this one. First, you find out what is the triggers. Is it lack of sleep? Is it irregular medication? Is it fasting? Is it the precipitating factors like sound or a light? Or if it is a hot water epilepsy also, we tell them that avoid very hot water, so much of a temperature of the water. Or if it is required, maybe we tell them to take clobazam before doing Those things we should do, tell them. And whenever they travel, wherever they go, see that they keep at least the drugs there. And even when I ask them to buy, suppose if it's a month drug is there, even 3-4 days before the drug means drug stock getting over, they should tell them to refill all the drugs, keep, so that they never should miss even a single dose of the drug. I think that's what we should tell them, especially the caregivers who takes care of them also, especially kids or older people. They may forget, like what it was mentioned, somebody has to supervise whether they're taking the drugs, especially children, school. If they are in the hostel, we should tell the hostel warden, see that the regular stock of the drug is there and they are taking on time. That's what I think, sir.
Dr. Manjari, you have mentioned about the pre-hospital medication for status epilepticus. Do you think that pre-hospital?
Yes,
sir.
Satish, I also want to talk something.
Yes,
Yeah,
sir.
regarding the same question, sir. Lifestyle.
No, whatever, I want to talk something
Huh.
about International Epilepsy Day.
Yeah.
On this day of International Epilepsy Day, first thing is good messages has to be told to the non-neurologists and public also. That is, epilepsy even today is a totally clinical
They were talking at the
diagnosis.
last, sir. That's what I was wondering. I'll keep it at the last. That was the reason I kept it. That's what. Okay,
So
sir. Please go ahead. Go ahead.
even today, it is totally a clinical diagnosis. So you don't need hi-fi investigations. And Dr. Mani and myself, we had done a Elandur survey there, about 60,000 population, and we used only in 4 patients CT scan and EEG. All the rest of them were managed purely on clinical diagnosis. And today we have got the mobile phones where they can record video of the attack so that we can differentiate non-epileptic attack from the epileptic attack. Now, the other good point is, so we need not do EEG and MR scan. Many times, first time when I say that probably you have got epilepsy, and when they advise EEG and MR, they bring it. Sir, EEG and MR are normal. Then we are very happy it is not epilepsy. When I said, unfortunately, EEG and MR in a large number of them are normal. So we don't necessarily do as a routine. The second good point is that 75 to 80% can be well controlled with basic drugs. Unfortunately, today, as a knee reflex action, everybody prescribes levetiracetam, the two starting higher dose 500 mg BD, which costs something like 40 rupees per day to be taken for next 2 years. Doctors do not consider the socio-economic condition of a patient when they are prescribing a medicine. Drugs like carbamazepine, valproate are more effective than levetiracetam, but levetiracetam has come in as a girlfriend saying that your wife has got so many side effects, phenobarb, phenytoin, carbamazepine, so I am a very good person. But now we know levetiracetam also has got lot of side effects. So the message is kindly prescribe cost-effective and more pharmacologically effective drugs like carbamazepine, even phenobarbital and sodium valproate. The other good point is that there are no restrictions on epilepsy. People ask, what are the food restrictions? What is this? What is that? The person with epilepsy is 100% normal between the 2 seizures. That means he can do whatever he wants, whatever profession, whatever he's got, except for swimming and driving, the two for a period of 1 year seizure-free period. No restrictions, easily treatable, clinical diagnosis. So what is the problem now? The problem is the society. The problem is that they don't get a job, they don't get school admissions, and more important now, driving is not allowed, and they are denied life insurance, and they are denied medical insurance, health insurance. The moment you write epilepsy, the health insurance is denied, even though according to the IRDA, they are supposed to give insurance for them also. So right now, Satish and the IEA they are struggling to get a driving license for people with epilepsy with some conditions so that they can start driving. Of course, practically we see everybody drives. I have got patients of auto rickshaw drivers, cab drivers, private taxi drivers. I only tell them, give me your vehicle number so that I won't sit in next time when I have to go. Because we can't do anything more. When I tell them you can't drive, they say, how can we live? That's also a problem. So, basing on the worldwide problems, worldwide situation, the driving is allowed in many countries if you are free from seizure from 6 months to 1 year. So in my practice, I tell them if you are seizure free for 1 year, you can drive, provided no late night driving, no early morning driving, and
Shortly there
preferably
will
no
be
long distance
shortly there
driving.
will be the act which is changed and it is coming to the picture, sir. It is shortly it will be there in the newspaper even. The parliament is going to pass that very, very shortly. The driving and epilepsy Indian law is changed and that will be coming into the picture. So we will have the rough guidelines for driving and epilepsy. I'm sure somebody would have asked for that, but there will be soon the guideline which is issued by the government for the driving and epilepsy is coming up. And also insurance, similar way. We are working towards that, and that will also be changing. And hope that Indian Epilepsy Association will be able to get this change soon, sir.
That's what I said. IEA with Satish and Manjari and all that, they are trying to get the driving license restrictions removed. And
Yes.
of course, removing a law is easy to pass, but implementation is very difficult. For example, marriage was a reason for divorce earlier. And Dr. Mani and others, 1999, the law has said now marriage is not epilepsy is not a contraindication to get married. But that is a law. But who is following it? We are seeing every day there is a no entry board and a policeman standing there, but still people go like that. So that is the problem. Law is there. I don't know how much the law will be effective. So these are some of the things. And finally, we do not still have anti-epileptic drug. We have been using the word AED, anti-epileptic drug, anti-epileptic drug. Only recently we have realized that it is really not anti-epileptic. It is only anti-seizure drug. We are yet to find an anti-epileptic drug or a disease-modifying therapy. What we are giving is like paracetamol for fever. So we are giving anti-seizure drugs to control the seizure and wait for the natural history to remit. So I thought I will just tell
Yes,
them.
you have summarized very well all the points which have been listed out for me at the end of the talk. I was thinking that we have already finished the time, or do you have time, sir? Rather,
Yeah, we can conclude, sir. No problem.
we can conclude. I think there was one question people are asking for status epilepticus. How do you taper anti-epileptic drug? Dr. Manjari, just
So
you can
state-
conclude very briefly so that I can close it.
So status epilepticus is one condition where we can liberally use a cocktail of drugs to stop the seizures. Once the patient is completely seizure free, is out of the ICU and normal, then the drug which probably we started first, which failed, we can try to taper it, but I am not in a hurry to taper. I send them home on the same drug. If they're having side effect to a particular drug that we have given in the ICU, like severe ataxia is there or severe tremor is there because of valproate, then I reduce that drug, but I send them on the drugs and I call them for the first follow-up. Usually the first follow-up is done after a month. And based on how they are doing, what drug is producing the side effect, which drug is safer for the person, I start tapering one drug very, very slowly. And hopefully by then we know the cause of the status. If it is autoimmune, we are also giving immunosuppressants, which will work. If it is meningitis, encephalitis, it is cured. Then we know that meningitis is gone, encephalitis is gone. We gave the cyclovir. Then also, after about 2-3 months, I start tapering one drug. Usually they are on 2-3 drugs. So I taper slowly, one drug at a time, and I allow the patient to be on one drug. I don't remember doing anything in a hurry in patients with status epilepticus.
Thank you, Dr. Manjari. I think with this, we will be concluding today's program. At the outset, I thank Dr. Sangram Biradar as well as Dr. P.S. Shankar and API and CSI for giving this opportunity to discuss on about epilepsy on this important International Epilepsy Day. And this is a message to all our colleagues who are treating epilepsy. Though epilepsy is a neurological disorder, it is more often treated by the general physician, pediatrician, sometimes psychiatrist, along with the neurologist. So, as Dr. H.V. Srinivas was summarizing, epilepsy is a treatable disorder. One can treat very, very effectively, like hypertension or diabetes, but only thing is it requires long-term management. It is not a short-term, it is a long-term management, and patients should be chosen an appropriate drug which is ideal for the patient based on their type of epilepsy, their frequency of the seizure, as well as their nature of work involved. And based on that, you choose a drug, and then the appropriate drug is continued regularly. We can prevent the epilepsy. We can control the epilepsy, manage the epilepsy, at least in 80% of the cases. And some patients who are getting seizures, despite the use of effective anti-epileptic drug, may end up with refractory seizure, and there the role of surgery or other modes of treatment has to be taken, and such patients need to be referred to a good center where the neurologists are working in the field of epilepsy, and they will be able to help these patients. And most important in the field of epilepsy is the myth and misconceptions and the stigma in the society. I think we all have to work toward this and remove the stigma in the society. And this International Epilepsy Day is meant for creating the awareness among the people, among the general public. As Dr. H.V. Srinivas was mentioning, we have to create awareness among the general public, not only among the patients or patients' relatives, and they should be aware of epilepsy. And once they are aware of epilepsy, their misconception and myths can be avoided, the stigma can be avoided, and they can lead a healthy, active life. That's all. With that, I conclude today's meeting. And once again, thank API for giving this opportunity to all of us. I thank Manjari for a wonderful talk, though there was some interruptions because of the unforeseen technical glitches, and Dr. Vengamma for giving the comments on the panel discussion, and Dr. H.V. Srinivas adding his wisdom and thoughts to the public. Thank you very much.
Thank you, sir.
so much.
Thank you, sir.
Thank you, organizers.
Thank you,
you,
Thank
sir.
you.
Thank
Thank you,
you.
Dr.
Yeah.
Srinivas, Dr.
Yeah.
Satish Chandra, Dr. Vengamma, Dr.
Thank you.
Viradar, all. Thank you all. Yeah.
And I request
you.
Dr. Suresh Sagrat to concluding remarks and vote of thanks.
Thank you, Dr. Sangram sir. On behalf of APA Karnataka and ICP Karnataka, I thank all the participants and the panelists. Dr. Satish Chandra has already proposed a vote of thanks as a conclusion. So, but still, as a customary, it was a wonderful program, and I thank our Chief Guest Dr. G. Narasimulu and also guest of honor Dr. P.S. Shankar and Dr. H.V. Srinivas sir. And Dr. H.V. Srinivas sir brought about the issues of socio-economic things to be considered in the management of epilepsy and public awareness. So thank you very much, sir, for bringing out those issues which are very relevant to Indian context. And also, I thank sincerely the speaker, Dr. Manjari Tripathi Madam, who is HOD Neurology, AIMS, New Delhi, for that wonderful talk and also participating in panel discussion. And my special thanks goes to moderator Dr. Satish Chandra sir, senior neurologist and former director NIMANS, who ably conducted and moderated the session. And also our sincere thanks to Dr. B. Vengamma Madam, Senior Neurologist and Vice Chancellor of Kolar University, and for all the participants who actively participated in this program. Thank you very much. And ICP Karnataka will continue to hold similar such programs in most of the health days to create awareness among physicians as well as the public. With this, we will conclude this session. Thank you very much for everyone. Thank you, sir.
Thank you,
Thank you,
sir.
sir.
Good
Thank you,
night.
madam. Thank you.
Thank
Thank you,
sir.
one and
Good
all.
night.
Thank you, one and all.
Good night.